Hey guys, this is Jessie Wolf, the Stroke Program Coordinator for Sanford Hospital. Welcome to Comprehensive Stroke Education. This will be session 1 of 2020. While we're looking at education today, make sure this is a taped session of the live classes, so make sure when you are viewing this that you're clocked into your home unit with your education code. This will sign you into the sign-in sheet. And then make sure you get some communication to me, Jessie Wolf, that you are taking this as a makeup class so we can get you officially signed into the sign-in. Today we're going to hit all the required topics from Joint Commission for all the group. We're planning our next sessions, and next sessions will likely break down into individualized units, ICU, emergency department, IR, etc. On the agenda today, we'll listen to Eric from Interventional Radiology. He'll talk about groin and radial site care. Emily Hutchinson, she'll talk about neuroassessment. Myself, I'll be talking about all the fun stuff, the documentation, Joint Commission, stroke updates. After Eric, Emily, and my sessions, emergency department staff that are attending this session are excused. They do not have to listen to Todd's side, but it is very informative and educational. If you'd like to, please stay and listen. And then Todd Persons is going to talk about bleeds and neurocritical care. So what is comprehensive stroke certification? It's a certification by Joint Commission. It's a 2-year certification. It's a 2-day, 2-surveyor survey. We anticipate fall of 2020 survey. Current certification that we obtain is primary stroke center. So what that means is we have the ability to treat patients with TPA, and we have neurosurgery available 24/7. Technically, we've been acting as a comprehensive stroke center since 2012 without the certification. A comprehensive stroke center is a more prestigious designation, and with that we would have the ability to treat all stroke patients, ischemic, hemorrhagic, TPA, and aneurysms, that we don't have to send our patients out for any sort of treatment. With this comprehensive stroke center certification, we would have projected increased volumes. So what will change for us? We've been taking care of these patients for quite a while, but the education is the biggest change that come with certification. That more nursing education for stroke, 2 years every year by emergency department, which isn't too far-fetched from what we've been doing, and then 8 years annually for inpatient staff that will touch all stroke patients. So critical care, 3,800, the core unit over there. Neuroacute, 5,000. Interventional radiology, therapies, pharmacy, and case management are all included in this 8 hours of education every year. Sanford is looking at breaking this into a 4 and 4 hour class, so break out into 2 sessions. With the survey, they'll look closer at our hemorrhagic strokes and interventional patients, as well as aneurysm care. This is boasted to be a very tough survey. Every survey we go through is a little bit tougher, but they said this is a really tough survey. They dig pretty deep. They'll look closer at how patients move through Sanford Medical Center and transition out of the hospital, so that case management involvement is key. If achieved, we would be the first comprehensive stroke center in all of South Dakota, which would be very cool. Big key to comprehensive stroke is that we're doing a lot of research, and there'll be more to come on this, lots of ideas coming forward. So, comprehensive stroke. Our objectives are to define our current stroke measures, what we have to meet to be a primary stroke center, introduce new comprehensive stroke measures, review IVTPA post-care and documentation, look at the groin site documentation, groin checks, site documentation, swallow review, NIH review, stroke handoff report, which is new. Primary stroke measures, I know we know these, but just what the measure actually is and how we meet it. Primary stroke, we do care for hemorrhagic and ischemic stroke patients. Not all the measures apply to both diagnoses. So on this slide, the bold underlined are ischemic plus hemorrhagic stroke patients. So all patients must meet those. If they are not bolded and underlined, it's just the ischemic stroke patients. So the first one, thrombolytic therapy. This is considering patients that are eligible for IVTPA for ischemic stroke only, that if they come in within the TPA window, we give them TPA or provide a reason why we did not, if they're contraindicated. VTE, sequential pumps on all these patients. Sequential pumps help prevent DVTs and blood clots in these patients. So getting them on as soon as we can and documenting them on as soon as we can, we're great at that, both hemorrhagic and ischemic stroke patients. Antithrombotic therapy by day 2. So this is an ischemic measure that patient's coming in with an ischemic stroke that we're treating them with antithrombotic therapy. That's a fancy word for aspirin, Plavix, or for their anticoagulation. And then we're also discharging them on that antithrombotic medication, the aspirin, Plavix anticoagulation. If that patient is an AFib or a flutter, we are treating them with anticoagulation for that. Aspirin and Plavix are not strong enough to meet this anticoagulation measure. It's the Coumadins, Eliquis, Pradaxa, those heavy hitter actual anticoagulation medications. We do tell staff and patients that if a patient is elderly, they come off their Coumadin because they're a fall risk, etc. Dr. Kim and Dr. Sandy will likely have that conversation with them that, you were taken off of this because you were a fall risk, but it caused a stroke and we likely need to restart it. So they really have a deep conversation with patient and staff on that anticoagulation factor. They're discharged on a statin if their LDL is greater than 70. So we draw that lipid panel on all ischemic strokes when they come in, that's on the order set, and more than not are their LDLs higher than 70. If that patient has history of statin allergy or intolerance or refuses, we just need to document that they're not going home on a statin because of those reasons. Typically, they discharge on a statin. Both Dr. Kim and Dr. Sandu follow best practices and look at Lipitor as that statin if they're starting one and they haven't had intolerance to it before. Stroke handout or stroke education. Within this measure, there's a couple different ways to meet it. We have to give that patient handouts and then documented best practice of that. We give them handouts, we do that education, and that patient can teach back what we taught them. Assess for rehab. This is meaning PT, OT, ST sees them and make recommendations for rehab post-hospitalization. Additional fallouts that we watch for is dysphagia, swallow screen before oral intake or meds, neurals and vitals after TPA, use of that stroke order set. And these are more PI projects within the hospital than measures. So comprehensive stroke, these are primary measures. We've been doing this for years. Comprehensive grades us on all of these plus the new measures. So the comprehensive stroke measures on this slide, you'll see where it's bolded and highlighted. Those are really nursing measures that we have to be careful to follow. A lot of the comprehensive measures, fortunate enough for nurses, is a lot of physician documentation. So the first, NIH on arrival, that stroke score on arrival, if they get IV TPA or go to intervention, we have to have that NIH documented before that patient starts that procedure or is administered that medication. If they're not a candidate, we have to have it within 12 hours of arrival. One new caveat to this as well is we complete an NIH after treatment of IV TPA and intervention on admission to the unit, so we do repeat it. Modified Rankin score is a functionality score for that patient, how much assistance they need with their with their activities of daily living. We do this at 90 days on our patients. They usually have a 3-month follow-up in the clinic. If they're unable to make that follow-up appointment for whatever reason, we give them a call. Severity score for ICH and subarachnoid patients. So ICH score shows how large that bleed is and is supposed to predict mortality. Subarachnoid hemorrhage grades that bleed. This is a neurocritical care grading, and that's to be on the chart within 6 hours of arrival, so usually within their H&P. Procoagulants for bleeds if INR greater than 1.4. So you have a hemorrhagic stroke patient coming in and they're on Coumadin. How long does it take us to get that medication on board and reverse that INR before their bleed gets bigger and worse? The neurocritical care team is wonderful about starting this, and typically they have this started and completed before the patient even arrives at Sanford if they're transferring in. Really good. That team is great about getting this reversed as fast as they can. Hemorrhagic transformation of IV TPA or intervention. So this is a patient that has IV TPA or intervention and bleeds post. Within our order sets, you'll see when they have ischemic stroke that we're to complete that NIH if that patient declines. So we do it on admission and with narrow decline per the order set. If that patient has just real petechial hemorrhage, just a slight amount of hemorrhage on there, but their NIH does not decline that 4 points. It's not symptomatic. So that's a way to help grade that patient after treatment. And nimodipine within first 24 hours. ICU is very versed in this. Dr. Burris and Dr. Berger's team does this all the time, just getting that in within the first 24 hours. We're great about getting it in right away, just making sure we do that swallow before. Nimodipine will help prevent vasospasms in those subarachnoid hemorrhage patients. So the nimodipine is just for subarachnoid hemorrhage patients. Median to time to first pass of those patients that go to intervention, how long do we move them? How long does it take us to move them through the emergency department down to the IR lab and get started on them? The faster, the better. TICI score, TICI stands for thrombolysis and cerebral infarction. So after interventional radiology treatments, what is our TICI score? A TICI 2B or 3 is considered successful. It goes from TICI 0, TICI 1, TICI 2A to TICI 2B and 3. So how successful are we in getting those clots out? How long does it take our patient to go through emergency department to get that groin puncture or radial puncture, whatever puncture site they use? A favorable 90-day modified Rankin, so kind of bumping back up to measure 2, that we complete that modified Rankin score at 90 days, and how many of them are doing better. And then measure 11, timeliness of reperfusion, how long, so we kind of measure how long from arrival to IR, arrival to groin, arrival to TICI score, and how long that takes. So moving our patients through the house in a timely manner is a lot of the comprehensive stroke measures. Other considerations for Comprehensive Stroke Center, we talked about the 8-hour inpatient nursing education, which was really a key. That was really what Sanford Sioux Falls was kind of waiting on, and dragging our feet a little bit that it's a lot. Case management role in discharge and family involvement in the education of discharge planning. So that case manager is talking to the family, looking at their needs and how well we're meeting them. Research requirements, as we spoke, that we have 24/7 care, that we can do MRI, CAT scan, doctors are available 24/7 and pharmacies available 24/7. We provide care to 20 plus aneurysmal subarachnoid hemorrhages every year, so a subarachnoid caused by an aneurysm rupture. And then we treat at least 25 IVTPA patients per year and at least 25 aneurysms, which we do meet this. We look at carotid endarterectomy and carotid artery stenting outcomes, which is new to us, kind of digging into that vascular world a little bit and seeing how those patients are doing with those elective procedures, and document. With every Joint Commission, they really look at our documentation and how we do this. We might do it well, but how we document it is how we tell our story. So even with our current survey, they look at post-TPA care very closely. You'll see on the order set that we are required to do neuroscience every 15 minutes to start, and vital signs every 15 minutes to start. We do every 15 minutes for 2 hours, every 30 minutes for 6 hours, and hourly for 18, then move to every 2. So why do we do this so closely? Guidelines guide us that this is for the best care of that patient because they have a 6% chance or less of bleeding after IVTPA. So those changes that we're watching for when we're doing this neuro check, we're doing it for a reason, because we're watching for a change in level of consciousness. They might become more sleepy. This is a little bit of a slippery slope when we're giving IVTPA to the elderly and they're not used to not sleeping. We keep them awake every hour through the night. Change in blood pressure. We really don't want to see a spike in that blood pressure. We want to even keel within our parameters. We don't want to see it spiking and valleying. Bleeding, if they have a Foley, we're watching that for blood. We watch if they start having nosebleeds or vomiting with blood in it. Worsening of those stroke symptoms and calling physician if they do worsen. And oral angioedema is a really rare side effect, and many times that's kind of what Joint Commission is looking for, those rare side effects. Oral angioedema is airway, tongue, and swelling. It's an allergic reaction, that TPA, that they're actually closing off their airway and having tongue swelling. We've seen this a couple times in the last even 2 years. We've seen a couple patients with this. Typically, it's a allergic reaction with something with the IVTPA, and when they're on a lisinopril-like drug, that combination can cause this. So watching their airway, listening to them talking, etc. If we see any of these symptoms, we would stop that IV infusion if it's still going, alert the MD, increase vitals if we're on every 30 or hourly minutes, we'd back up to every 15s again. redo that NIH score and prepare to go for CT scan. I've told every nurse that's taken this course that Dr. Sandhu is likely right, but these patients would benefit from sleep hygiene during these TPA checks, that when they're 99 years old, we give them TPA and we keep them up every hourly. They typically do worse that first day or become delirious, but guidelines say we must wake them up. We can't do sleep hygiene unless they're comfort care in this phase. So Dr. Sandhu's right, but guidelines say we must do it this way.
So Joint Commission will look at our neuro and vital signs checks post TPA administration. They give us a 5-minute window. If we're past that 5-minute window, the check is considered late, and then we do not get credit for completing it. We try to assess our neuros and vitals together. Change in vital sign will catch a neuro sign, our neuro change easier for us. So the vitals and neuro should both be checked at the same time. For example, 1715 should have a full neuro check and a full vital sign. We can do vital signs during MRI. We are unable to do a neuro check during MRI. Of course, do not stop the MRI, do the neuro check on the patient. Just complete a neuro check when that patient comes out of MRI and then get back on track where you were with your assessments. Ensure the blood pressures are within parameters, that 180 over 105 parameter. If we're creeping too close or even over that parameter, do we need a drip to keep that blood pressure in the even keel? You will see this flow sheet on the slide with the patient. So, for example, this patient started TPA 1/1 of 2020 at 1703 and 1705. Go ahead and start every 15s after that. You don't have to have a funny start time like 1723 on the button. This patient restarted at 1715 to make it nice and clean. 1730, 1745, 18, 1850. And the check here means that this nurse has completed this neuro and vital sign check and documented in Epic. This is a nice handoff tool for that patient when they go to every 30 minutes. That nurse will know when the 30 minutes starts, etc. And this is not a permanent part of the paper. It's just a worksheet for the staff. TPA past 24 hours is a new 2020 stroke guideline. It's saying that some patients, select patients, the right candidates, can receive that TPA from 4.5 up to 24 hours. Stanford Sioux Falls is doing this at this time. To find that good candidate, we need a STAT MRI limited. We compare the diffusion weighted imaging, DWI imaging, to see how much of that brain is affected by that stroke. They might be 7 hours out from their stroke, but their brain is having those ischemic changes very slowly. So the best candidates for this, they have a large NIH and a small ischemic core on that DWI imaging. Stanford Sioux Falls and Worthington right now are the only two sites that have CT perfusion scanning imaging. So those patients will have the CT perfusion scan, likely at Stanford Sioux Falls, followed by a STAT MRI with the DWI imaging, and then they'll compare the two to see that the stroke will be a large stroke with a small amount of already damaged tissue. Guidelines are a little fuzzy still. They're saying we can do this up to 6 hours, 8 hours, 12 hours, up to 24 hours. The windows are still needing research. Knowing our stroke team, they're super aggressive. They've been doing this since the start of the year. We go up to 24 hours to find those candidates to give that patient the best opportunity we can. When we're treating these patients, the only thing different is Dr. Kim and Dr. Sandhu will have to do a specialized consent with them, but we treat them the same. We do the neuros and vitals the same and all the same as a typical TPA patient. Brain checks is something comprehensive stroke will really look at carefully as the IV TPA neuro and vital signs checks. So when you see this patient come up from intervention, angio, etc., anything done in the IR lab with Dr. Kim and Dr. Sandhu, you should see orders as on the screen that we check those pedal pulses and mark it with ink. Vital signs, post-radiology procedure, every 15 minutes for 1 hour, then every 30 minutes times 2. Checking that angio puncture site for bleeding or swelling with those vital signs, and checking CMS on that appropriate extremity. Check the distal pulses and assess puncture site for bleeding. They'll go through and make sure that we're doing this appropriately. You'll see some PI projects coming up that will start monitoring this with that worksheet, just like the IDTPA worksheet. It is helpful to march these out just like we do in the TPA flow sheet, that 5 minutes past, it's a late check, it doesn't count. So make sure that it's getting within that every 15 minutes when that patient first comes back to the unit. Stroke education. To meet this measure, like we talked about, we need to give that patient handouts. We have 2 opportunities to do this. We have handout education for admission and their after visit summary on discharge. Joint Commission really wants to see that we're not a cookie cutter stroke center, that we take that patient and we treat them the same, but we personalize our treatment to them, their risk factors. So when you open this up, you'll see on the left that essential stroke education. That we're handing them the book. Below it, it says identify personal risk factors. It's artery disease, atrial fibrillation, diabetes, excessive alcohol intake, etc. Joint Commission wants to see that if that patient is not a smoker, is not a diabetic, that we're not saying we're educating them on quit smoking, it will cause another stroke. So we should resolve those risk factors out of our personalized patient education. You'll see off to the right, we speak to how we give those patients their education. This patient documented on the screen was very confused, came up to the floor, no family with them. So we documented that we gave the education to the patient. They accepted it. It was a handout. That's really important to tick that handout when it's in the patient's room, but it needs reassessment. That patient, we need to keep reinforcing their education. When we add the stroke discharge education, it's .smcdc stroke, and it will personalize for the patient. Swallow screening. All strokes need a swallow screen. Also TIA patients need a swallow screen before any oral intake or any medication intake, and we need to document. We do great at this. It's the documentation piece that sometimes gets us in trouble. Our biggest opportunity is that we can document failures. This patient is very sleepy, will not wake up, is not managing their secretions. I'm not going to complete a swallow screen on them, document it at that time. For example, at 9 o'clock in the morning, patient is initial screen, the first answer is no, stop at that point. This patient on the screen, you can see the time is 8:41. We inserted that time because that's the actual time we completed the study. And if you've never done a swallow screen, the documentation will walk you through it, that this is the initial dysphagia screen. Sit the patient upright, head of bed up 75 to 90 degrees. Are they able to open their eyes and focus? Yes, was the answer. Do they have any of the following? And when you hover over, you can see off to the left, unable to handle secretions, drooling, weak or absent cough, hoarse or absent voice, or none. So this patient has none. And then it talks about providing 90 cc's of water. That 90 is a really important number. It's evidence-based. That's the amount we need to give them. You can give it to them with or without a straw. You can assist the patient to hold that cup up to their mouth if they need be, whatever it takes to help that patient. Are they successful? Do they drink the whole 90 cc's of water? This patient, yes, they did. And they passed the screening at the bottom. If they weren't, if they were to take a drink and start coughing, I'd put no in there, and the box below where it says check all that apply will tell you, and one of the options is patient coughed, and then keep that patient NPO. A diet is ordered on all these stroke patients. When you open a stroke order set, you will see the diet is ordered NPO. And then under diet message, it says swallow screen before any oral intake. So they need to be NPO until oral intake, or until swallow screen completed. If they pass, you can see the last order there. If they pass, we can start them on a regular diet. No patient wants to be NPO when they can swallow. So that's one of our biggest complaints, that NPO order throws staff off. We want them NPO until the swallow screen. If they pass, start them on a regular diabetic diet, whatever they need. Don't keep them hungry. If they do fail, that it shows you that you can go ahead and consult speech language pathology or speech therapy to do a swallow screen on that patient. NIH to document, we're seeing with that new measure, we need to insert the time we completed that NIH scale. For example, in this documentation you see on the screen, the time is 9:40. The patient arrived at 9:40, and the documentation field says 9 o'clock. So if I don't insert my 9:40 time, it looks like I did the NIH scale before the patient arrived at Sanford. The new measure, make sure we're doing that NIH completely top to bottom before IVTPA procedure, otherwise within 12 hours of arrival. You'll see attached with this, we need to do an NIH training every year. So part of this first 4-hour training is NIH training, and I'll get into that. To complete the Sanford Learn NIH stroke scale, it's a little tricky. Please call me if you need help with this. But when you're looking it up in Sanford Health or Sanford Learn, it's CA8982. When you find it, it will open all of these measures or all of these NIH tests below. We're the bottom one, so you can see we would launch it at that time and start. It opens up this first page because all of the Sanford sites use different training modules. We use that blue cloud, the first blue link at the top of the page. So find that link, click into it. It will make you log in or make a new account, and you pick one of the patients, watch how they complete the exam, and take the test afterwards. It does take some time. The videos are a little slow, so you can log out and come back. When you're completed, print the certificate and get it to me any way you can. Take a picture of it, email it to me, drop it off in the office, give it to the floor director. On this slide, it says due March 1st because that's where it was with our initial education. The tricky thing is you have to go back into Sanford Learn and mark that complete box. I'm going to slide back to the prior slide where it says mark is complete. So I've done all my training, and then I go back and mark complete. Plavix and aspirin are stroke interventional patients. We want everybody to take special note to Dr. Kim and Dr. Sandu's treatment. So if that patient's having any procedure treatment with Dr. Sandu and Dr. Kim, they will order that Plavix and aspirin. We do not hold that for their procedures. It's really tricky and complicated that a lot of surgeries we hold Plavix aspirin. With strokes, we do not. Some of these key treatments are stent placements. If we hold Plavix during a stent placement, that stent will clot off and that patient will stroke again. So carotid stents, intracranial stents, aneurysm treatments with stent assistance, cerebral angio with possibility to stent are some of the main treatments they do. They will commonly load that patient with Plavix the night before, either 150 milligrams or 300 milligrams, and then load with aspirin, either 81 or 325 milligrams. So that will be the night before the procedure, and then it will order just routine dosing on the day of procedure. They will have an NPO diet, but we want them to take those meds. Those two meds are specifically important. When you read their order set, it's in fine print. Do not hold those. A P2Y12 test might be ordered 2 hours after the dose is given the day of treatment to see if they're responding to that Plavix. And then if they are not responding, they might give them some different thinners during procedure. Risks of missing these doses: a stroke during procedure, a stroke after procedure, or that clotted stent. IR is working awesomely for some checkpoints when sending for this patient. They'll collect report on these patients and ask these questions. Did they get last night's dose? What was the dose? Did they get their dose this morning? What was the dose? Have you drawn P2Y12? Was it ordered and have you drawn it? Do you have the results? Just to try to tick off these boxes a little easier for us. Stroke blood pressure guidelines, always follow your order set parameters. Meds and goals may vary depending on history, what their vasculature looks like, and the size of the stroke. A prediction is that blood pressure guidelines will be changing soon. Research is looking at normotension as a more appropriate treatment for ischemic strokes, but we'll follow the guidelines. SMC follows American Stroke Association guidelines. So generally, unless otherwise specified, a hemorrhagic stroke blood pressure should be 140 to 150 systolically. Potential for drips. Increased blood pressure in these bleeds will make their bleed increase and make them very much sicker. Ischemic stroke that has had TPA, that goal less than 180 over 105, we do not want to be chasing blood pressure. We want good ongoing control. Blood pressure spikes can increase that risk of bleeding after TPA. Intervention, the parameters will be placed in the order set. Generally, they kind of follow the TPA parameters as well, but depending on if that patient has a lot of stenosis, we might change the blood pressure parameters up. A patient who has an ischemic stroke without TPA, without intervention, has permissive hypertension parameters, 220 over 110 for the first 24 hours. This allows for brain perfusion. Watch for low blood pressures on how they tolerate their activity and what their pressure is doing when they're starting therapy. After 24 hours, it drops down to that 185. Level 1 and Level 2 stroke codes. This was brand new when we did this education in January, but kind of getting dated now that we're catching up. Our inpatient stroke codes have gone through major changes. A rescue nurse can now activate an inpatient stroke code based on those symptoms of stroke for that patient. Rescue nurses are the only ones who can activate an inpatient stroke. Physicians may, but rescue nurses are the only nurses who can. When they activate an inpatient stroke code, they directly access Dr. Kim and Dr. Sandhu via their cell phones, and they have orders for CTA of head and neck and labs if they need. In emergency department, a level 1 stroke code is an onset of 4.5 hours or less, so that's standard TPA candidate. They get a CTA of head and neck. Level 2 is an onset greater than 4.5 hours up to 24 hours. We do the standard CTA of head and neck and add CT perfusion scan on this level 2 to see how much of that brain tissue has been damaged. We may use that limited MRI stat if they're going to obtain IV TPA past that 4.5 hour window. In the past, we would room these patients, do an NIH, and if the NIH is greater than 6, we couldn't call a level 2 if they were an NIH of a 3. Right now, it's any discernible deficit. They have any stroke symptoms from 4.5 to 24 hours. They're a candidate for a level 2 stroke code. In the future, we'll be using video monitoring for these stroke codes. For example, Dr. Kim could video in and see that patient if he wasn't directly at bedside. If he was driving in or at home, he could video in and be in much quicker than that 5-minute drive into the hospital. Stroke handoff. This is a 2020 PI project plan that these patients are very sick and they can have very subtle neuro changes that we want to catch right away. So RN to RN neuro handoff report, the patients coming into ED and then into the stroke units, neuroacute, critical care, and 3800. When those patients come up, the ED nurse and the floor nurse will do a full neuro check on them. And then again, when those patients transfer out of those units for critical care and neuroacute, they go to 5 or out to medical, cardiology, etc. This is eliminating any slight neuro changes during transfer. It will start with a paper sign-off sheet, and then both nurses will sign that it was done, and we want this on 100% of our patients. Benefits of this, we have a lot of newer RNs just learning how to do a good neuro assessment, how to get in the swing of it, and they will benefit from a more accurate assessment. Receiving unit will see all the deficits that patient displays, and they're waxing and waning, and it's accountability for a safer patient. Important information that can be relayed is blood pressure parameters, swallows, vitals, etc. And we're seeing a neuro exam in person versus what it looks like in the documentation can be a huge difference. So this has been very beneficial for staff. And that is all I have for today. Thank you very much for listening. How's that, Don?
You absolutely kicked butt there, Miss Jessie.
Awesome.
You did
I have
really, really good.
The best timing.
Did she just come in?
Yep.
Oh, for cool. Well, hey, I am going to, well, while you're both in the room here and we have microphone control, let's talk about what we're going to do next here now.
Okay.
We'll go ahead and conclude this session, and then we'll go ahead and fire up the next session. That would definitely be that second invite that came out that says 11 o'clock, but again, don't worry about the time. It's no big deal. So this recording in its complexity is going to kind of take about 15 minutes to a half an hour, maybe even a little bit longer than that to render. And then I'll go through it and make sure that we marry up that first portion with the second portion that we did. And I'm pretty sure it's going to be pretty darn cool. Now, Jessie, will Emily be using the same PC that you're on right now?
Yep. Yep.
Okay, so she can log off and then come back in and use that little that blue button as an organizer to join. So, and you'll be over her shoulder for just a few minutes.
Yep. I'll
Wonderful.
log off. I'll log off and we'll log right back on.
Very good. I'll do the same. Thank you so much.